And I think we really need to move on. So it's a pleasure to invite Dr. Ajay Aurora, a leading practitioner in Delhi and one with a very innovative bent of mind is to speak to us on his experience in subthreshold micropulse lasers in RVO, regional vascular occlusions.
So can you see my slides?
Yes, yes,
can you hear me? So thanks Anand and thanks Saul for this opportunity. And I've been using micropulse lasers since 2015. So I'll be just sharing my experience on, these are my financial disclosures. Basically on non-ischemic CRVO and VRVO. So all cases in the macular area, I did 5% duty cycle, and outside the arcade, I did 10% duty cycle. Titration was done in the micropulse mode, a single one nasal to the disc. The power was brought down to 30% for the venous occlusions. For the acute CSR, I do 25%, and for the DME, it's 30 to 35%, and chronic CSR, it is 30 to 35%. I have used a multi-spot pattern scan with no burn distance, either 5:5 or 7:7. I still consider that macular thickness is important, and for me, the cutoff is 450 microns. I tend to bring down the macular thickness using anti-VEGF or steroids, and then use the micropulse laser. So I would not go into what has already been discussed. I'll probably skip these slides because I think this is just, so this is 76 years old. So these are cases. I'll just be showing you a lot of practical cases. 76 years male who is Army General, who was hypertensive, diabetic, had an operated C rectum. He presented with central venous occlusion. And he was very particular that he doesn't want an anti-VEGF in his eye. So he waited for almost about 4 months before he decided to go in for a micropulse laser. And that was the 9th July 2015 when he made the decision. His visual acuity at that time was 6/60. So we had treated him during this time with non-steroidal anti-inflammatory, and he was doing yoga and trying to do everything to get his macular edema down. That it was not down, he agreed for a subthreshold micropulse laser. So as per my protocol of the titration, I did it in the nasal to the disc, and we used 30 to 35% of the titrated one, and 5% duty cycle was used in the macula. And beyond the macula, we used a 10% duty cycle, and this was done in all 4 quadrants. The burns were 200 microns of 200 milliseconds with no distance between the burns. So this is how it was 3 weeks post-op, 6 weeks post laser. The patient's visual acuity has improved to 618, and this is during a follow-up of almost about till about August, when his visual acuity had improved to 612, and you can see the reduction of the macular thickness over a period of time. This is the 23 years old female. So this is the second case of BRVO, who is non-hypertensive, non-diabetic, who had sudden blurring of vision in the right eye with normal blood works, the serum homocysteine of 7.1, with no past history of similar attacks. So she had come to us, and initially she was treated. This was in 2014 when she was treated with Avastin. This is a clinical picture, and she had improved. This is how she looked like at that time. And then again, the edema came back. This is 11 February 2015, when a repeat injection of Avastin was given. And she was very particular. She doesn't want any more Avastin. So this is in March 2015 when we decided that we'll go ahead with the micropulse laser. And in April, we did the micropulse laser. I plotted out the areas of how much of capillary non-perfusion was there. So we discussed with the patient the options of repeated intravitreal injections or scatter continuous wave laser or subthreshold micropulse laser. When she decided, we went ahead and did a 10% duty cycle micropulse laser to all these areas. So how do I know that I have treated the area? I marked out the area with the normal continuous wave, And then I filled up that area with the micropulse laser, so that in case I have to repeat it, I have some boundaries marked out where I can actually treat. So please note this. This is in April 2015. This is the area of capillary non-perfusion. In August 2015, I could actually see some, I won't call it angiogenesis, but you could see some new vessels forming within that area. You can see all these areas have been marked out. So there was revascularization. We did a repeat micropulse laser again with 10% duty cycle. I have now followed up this patient for over now 7 years. And so she comes religiously every year. She's at the moment outside India. So you can see even the new patient had NVD, which gradually became more fibrosed. She had no conventional laser, only a micropulse laser was done, and the conventional laser, continuous wave laser, was only to demarcate the areas where we treated them with a micropulse laser. So this is over a period of time how the macular edema remains stable. And later on, when we acquired the angioplex, we have followed up on angioplex. And this is the montage of the right and the left eye. Now, what I want to point out here is 2018, this is what the macula was. There is a foveal thinning. This is the area of where there was a defect in the ellipsoid zone, which is about 528 microns, because she persistently said that though her vision was 6 parts, but she was seeing a distorted vision a little bit in the center, but she had significantly improved, and this is 2021. And this is the recent picture. She came back in April, where so I would actually ask later on ask the panel here that in the experience in such a cases, will it convert to a macular hole? Is there any point in operating at this stage, because the patient has about six parts vision, and a patient did develop a break in the inferior temporal quadrant, which is late. This is a third patient. This is again a branch vein occlusion, a 39-year-old male with no diabetes, hypertension, was not vaccinated, and had no history suggestive of COVID. Presented on 7th May, that is when COVID had started in 2020. There was a diminution vision in the left eye of 636. The right eye visual acuity was normal, and that's what the macular edema is. All routine investigations are normal. Patient received an intravitreal injection of eccentrics. So this is how the patient was. This is 7th May, 13th May. 13th May, the patient received that injection. And this is what the patient was on 26th June. Visual acuity has improved to 612. Now this patient I have now followed for over 2 years. Patient is absolutely stable, has had a, we did treat a second time of a micropulse laser. And this is recently when the patient had come to me. So we had given a 5% duty cycle in the macular area. And beyond that, we went ahead and gave a 10% duty cycle. So this is the mid-retina phase, the ANFAS image of in 6 September 2020. This is 14th July, quite recently in 2022, which is almost similar. Patient is quite happy with a visual acuity of 6/6 and has not been treated further, but is on a regular follow-up. So this is his recent angiogram and a wide field picture you can see here. So thanks a lot. This is why I wanted to share my experience with venous occlusion. Thank you.
Yeah, thank you, Dr. Ajay, for the fascinating cases, especially that one in which you treated that non-perfusion area. Very innovative and a very nice thought that you went with the barrage to delineate where you needed to do that, and you found a bit of non-perfusion. I think that was quite remarkable. So, does anybody in the panel have experience, treating branch vascular occlusions, and especially ones that are ischemic, the way Dr. Ajay's case was?
I have done small tributary vein occlusions with naturally after injection 1 month later it will recur. I don't have a definite data, but initially there will be some improvement. I combine it with injections, so I don't know whether the evidence is towards micro.
Yeah, the macular edema, yes. I think many of us have, dabbled in
macular edema.
For the
Not
macular
for
edema.
periphery.
But for the non-perfusion, that was an interesting thought. And I think you showed us that even the neovascularization at the disc regressed too. So that was quite interesting. And in another case, you used a higher duty cycle for the peripheral areas. So that was an interesting approach.
I just wanted to make a comment, very interesting work. And I am in favor of doing subthreshold PRP or subthreshold peripheral laser. We did a study when I was in LVP where we compared the peripheral PRP performed in one eye with the continuous wave and other eye with subthreshold laser. And we did find the benefit in cases of very severe NPDR, because we kept as progression of severe NPDR to PDR as one of the outcome measures. And it was very interesting to see that almost in a year follow-up, we saw that the eyes with subthreshold PRP also did not progress. And I think that Dr. Ajay Aurora has also done peripheral subthreshold PRP in PDR. And maybe there is really a role for subthreshold PRP in reducing the neovascularization progression, as well as, it could be considered as every 6 months PRP. So you actually prevent the field loss, as well as you prevent the progression to PDR. Dr. Ajay Aurora, you wanted to make a comment on this?
Yeah, so what I didn't present was that these patients which have done, I've also monitored that patient with a branch vein occlusion. I have a fields of 2015, fields of 2019, fields of 2021, where there are some changes which are evident. So I thought I'll present it at another occasion. But I've had 3 cases of proliferative diabetic retinopathy where we took the consent that we are doing the treatment which may not be the gold standard of not doing the conventional PRP. So for the NBE, I've done targeted laser, and rest of the area I've done micropulse laser. And now that I have a wide field angiography available at our own center, we will be able to monitor these cases much better. And I think the cases which I followed them up. 2 of them I followed for 2 years, and they are doing pretty well. So I'm pretty excited about using micropulse PRP, but I've never gone to the level of
Dr. Girdhar, we can
security in
in the interest of time, I think we'll move on to